Good evening, everyone, and welcome to Science Cafe. My name is Jenny King. I work in public affairs here at UT Southwestern Medical Center in Dallas. Our team is proud to produce and host the UT Southwestern Science Cafe series, along with my co-host, Charlandra Charlie Thompson, and our team member, Javelin Castellanos, as well as our speakers tonight and our many UT Southwestern colleagues. We thank you for joining us. Science Cafes are online conversations where speakers take you on deep dives into the science behind healthcare. As an academic medical center, UT Southwestern brings together research, health education, and patient care into one institution. Tonight's program takes us into the complex area of cancer genetics, counseling for patients, and precision or personalized medicine with genetics counselor Kelsey Moriarty and pathologist Dr. Jason Park. Before we start the program, I have a few housekeeping items to share. We are recording Science Cafe as well as live streaming it on the UT Southwestern Twitter page. Please mute your microphones. Thank you. As we are connecting digitally through Zoom, consider leaving your camera on so we can see each other, especially during Q&A at the end. And finally, while we cannot answer personal medical questions, we welcome your general questions about tonight's topic. Throughout the next hour, please list your questions in the chat. Charlie will address them after our presentations. And now I'm pleased to introduce our speakers. Kelsey is a certified genetic counselor at the Harold Simmons Comprehensive Cancer Center here at UT Southwestern. She meets with patients across the system to discuss their chances for hereditary cancer syndromes. Kelsey earned her bachelor's degree from Baylor University and her Master of Science in Molecular, Cellular, Developmental Biology, and Genetics with an emphasis in genetic counseling at the University of Minnesota. At UT Southwestern, Kelsey helped implement the Hereditary Hematological Malignancies Clinic, and she coordinates the Genetic Counseling Assistant Mentorship Program. Dr. Park is professor in the UT Southwestern Department of Pathology and the Eugene McDermott Center for Human Growth and Development and clinical director of the Advanced Diagnostics Laboratory at Children's Health. Dr. Park's clinical and research interests are in genomic medicine, gastrointestinal diseases, and clinical informatics. He is the author or co-author of more than 150 journal articles, book chapters, and published abstracts. Additionally, his research has resulted in 13 issued U.S. patents on cancer diagnostics, cancer therapeutics, and nanotechnology. Dr. Park's medical training began in the accelerated Bachelor of Science MD program at the Pennsylvania State University and Jefferson Medical College. After medical school, he was a pathology resident and chief resident in the Department of Pathology and Laboratory Medicine at the Hospital of the University of Pennsylvania. This residency was followed by a fellowship in gastrointestinal and liver pathology at Johns Hopkins Hospital. He joined the faculty here at UT Southwestern in 2010. Welcome to Science Cafe, Kelsey and Dr. Park. Kelsey, the virtual podium is yours.
Thank you so much, Jenny, and it's an honor to be able to talk to everybody today. I'm very excited to chat about cancer genetics. I'm going to share my screen. All right. So to begin today, I really did want to start us off all on the same page and throw it back to our high school biology days a little bit with a review of some genetic concepts. So our genetic information, also called our DNA, is like our instruction manual for our body. It can help tell us how to work and how to function properly. And our DNA is made up of genes. Those genes, some of them help tell us what hair color to have or eye color to have. Other genes also help tell us how to protect ourselves from cancer and help that process. And all of these genes are packaged into our chromosomes, and we have 23 pairs of chromosomes total. Of each pair, we get one from our moms at birth, one from our dads at birth, and they're all housed in the nucleus of every one of our cells. A term we'll use a lot during this talk today is pathogenic or likely pathogenic variant. This is also known as a mutation, and more commonly known as a mutation, and sometimes we also refer to it as a broken gene. So when a gene is working the way it's supposed to, it produces the proper protein, but when there is a mistake in that gene, then it can produce abnormal protein or no protein at all. And if we put this in the context of cancer, our cancer genes that normally protect us from developing cancer, if there's a mistake in one of those, it can lead to someone having a higher chance to develop cancer or lead to a cancer. To get in a little bit more to how cancer can develop over time, there's a couple different ways this can happen. So most of the time, people start off with their cancer protection genes working properly when they're born. And over time, we can acquire mutations. And once we have these 2 hits or 2 mutations, then our cells grow out of control and cancer develops. This can happen due to aging or other factors. And we can think of this like if we're writing lines over and over and over again, at some point, we're going to make a mistake when we're writing those lines. And our cells do the same thing. As they replicate over and over again, a mistake can happen. And that's what can lead to cancer developing. On the other hand, sometimes people are born with one of those mutations or one of those broken genes, and they just need one other mutation for their cells to grow out of control and cancer to develop. And so in this case, a lot of times when someone has a predisposition to cancer, we see them being diagnosed with cancer at younger ages. So we have come to our first poll question here. What % of cancers are caused by a hereditary predisposition?
Can you all see that on your screen? Doesn't look like it.
Yeah.
You can- Okay, so people are going to answer. There we go. So you all can click on the answer and see what you think the right one is for this question.
Just the first question.
Do you see all 4?
I see all of them.
Oh, sorry, everyone. Yes, just the first one, please. That would be great.
Well, we can go through these over time. It looks like we have about 50% of people saying 10% right now and split 25-25 between 50 and 30%.
Okay.
So we are on the right track with this first poll question, I will say. So I'll go ahead and go to my next slide here. And we can see that 10% of cancers are hereditary or due to hereditary predispositions. About another 20% is what we call familial cancers. So this is when we see a cluster of cancers in the family. And maybe there's some genetic component, but there's also maybe an environmental component going on for these families. And then most of cancer is going to be due to sporadic or what we call random chance. And this could be associated with things like aging, or maybe someone is a smoker or heavy drinker that can increase their risk to develop cancer over time. Next, I wanted to go over a few red flags for hereditary cancer. What are things in families that make us more concerned that there is a hereditary predisposition for cancer? One is an early age of diagnosis. Like I mentioned earlier, we just need that one more mutation over time for someone to develop cancer. So a lot of times if I see someone with breast cancer in their 30s or 40s, that can make us a little bit more concerned that maybe there's a hereditary predisposition. Also, if we see certain combinations of cancers, for example, if I see breast, ovarian, pancreatic cancer, and prostate cancer all in one family, that can make me more concerned for a hereditary predisposition. Or maybe there's a combination of colon and uterine cancer. That can also make me concerned for a different type of predisposition. Multiple generations, when they're affected, also is another red flag. So if we see grandma, mom, daughter, all diagnosed with breast cancer, it shows a strong pattern in the family. Next, if there are multiple cancers in one individual, maybe someone has breast and ovarian cancer, or maybe they have colon and uterine cancer, those things can make us more concerned. And finally, bilateral cancers are rare cancers. So if someone has cancer in both kidneys, bilateral kidney cancer, or rare cancers like male breast cancer can make us more concerned for a hereditary predisposition. There's a couple different ways that we can see cancer predispositions inherited. The most common one is going to be called autosomal dominant inheritance. And this happens, someone just needs one broken copy of the gene to have that predisposition. So in this case here, we can see the father has one broken gene and he has a predisposition to cancer. He then has a 50% chance to pass on this predisposition to each of his children. And then on the flip side, every now and then, there are some conditions that are inherited in what we call an autosomal recessive inheritance pattern. And in this case, we actually need two broken copies of the gene, one from mom and one from dad to have the predisposition. So in this case, we see each parent is what we call a carrier for the condition, and they have a 25% chance to have a child who has that predisposition, a 50% chance to have a child that is also a carrier like themselves, and then a 25% chance to have someone who does not have a condition, the predisposition, and is not a carrier either. So next poll question, and I believe you guys have already answered. Have you heard of genetic counseling? And a great majority of you have, which is fantastic to hear. I love that. So 88% are saying they have heard of genetic counseling. Just in case someone, I know we have a few who haven't, which is great. I'm glad we can introduce you to it here today. And the definition of genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of the genetic contributions to disease. So to put this in a little bit more practical stance, what happens during a genetic counseling visit? We begin by taking someone's personal and family history of cancer in these cases, and then we look at the family and try to put the puzzle pieces together and do a risk assessment to see what patterns are we seeing in the family that make us more concerned or less concerned for a hereditary predisposition. Then we can talk about genetic testing options and help determine if genetic testing is right for somebody and what test would be the best for them. Then we can also go over the results once those come in too and help coordinate care if they need to watch more closely for cancer going forward. We can make sure that's in place. And then, of course, have that support throughout the process. It can be very difficult to learn this information, and we want to make sure that we have somebody there to walk you through the whole process. Question number 3, what type of sample is used for germline or what we call inherited genetic testing? And it looks like we have 25% saying blood, 6% saying saliva, 6% saying skin, and then 63% said any of the above, which is the correct answer in this case. We can use any of the above sample types. So blood and saliva are probably the most common ones that people have heard of. We do sometimes use skin cells in people who have blood cancers, and where that blood or saliva sample is their cancer cells are in their blood. So we cannot use that as appropriate testing to see if this mutation is in all of their cells. So we use skin cells instead. All right, so there's a couple different genetic testing options that we normally talk to patients about depending on what's going on in their personal and family history of cancer. So the smallest option is usually just a single site test when there's a known mutation in the family. Sometimes if there's no additional testing indicated, we can just test for that known mutation. Sometimes we also have concern for just one specific condition. So we're just looking at one gene to see if there's any problems in one gene to cause a predisposition for cancer. And finally, the most common type of testing we're doing now is what's called panel testing. This is where we're looking at multiple genes associated with predispositions to cancer. And it can be either a specific type, like maybe hereditary breast cancer or hereditary colon cancer, or can combine a lot of different cancers and do predispositions to all types of cancers as well, depending on what's appropriate for the patient and what the patient is looking for in their information. When we get results back from genetic testing, they fall into these 3 different categories. So one we've talked about before is pathogenic and likely pathogenic variants, and this is what we call a positive result on a genetic test. And this means someone has a predisposition to cancer. They have an increased chance for cancer that they were born with. On the opposite side of the spectrum, the green boxes here is a negative, also what we think of as a normal result on the test. This means we did not find a hereditary predisposition for cancer for that individual. Doesn't mean someone can't get cancer over time, so it's still important to follow up based on everything that else is going on for a person, but it just means that we did not find a hereditary predisposition. And finally, that yellow box in the center is a little bit of a confusing one. VUS stands for variance of uncertain significance, what we call uncertain results. When we think about hereditary predispositions to solid tumors like breast cancers and colon cancers, about 90% of the time, those uncertain results are going to end up being negative or normal results in the future once we get more scientific knowledge. That uncertain result right now means that we just don't have enough scientific knowledge to put in the positive or negative category. So what if we do have a positive result? Now what do we do with that information? And I put a few examples on here, depending on what type of cancer someone is at risk for based on their result. So some people who have a higher chance for breast cancer are going to do extra breast screening. So that could include mammograms and breast MRIs in addition to that. Some people also decide to remove the breast to reduce their chance for developing breast cancer as well. With colon cancers, often it's doing colonoscopies more frequently than is generally recommended for most people. And in very rare cases, some people do have a surgery to remove the colon if the risk for colon cancer is very high. Then for ovarian cancer, the recommendation, if there is an increased risk, is to remove the ovaries. And in this case, it's definitely done with a discussion with a doctor, make sure the timing's right for you after someone's done having children, etc. And this is really because there's not great screening for ovarian cancer. We have certain exams like CA-125s or transvaginal ultrasounds that can be done, but they don't always catch ovarian cancer. And the same can be said for uterine cancer. When someone has an increased risk for uterine cancer, generally we think about a hysterectomy or removing the uterus. And again, we don't have great screening for uterine cancer. You can do transvaginal ultrasounds or biopsies of the uterus as well. For pancreatic cancer, if someone has an increased chance for pancreatic cancer, we do some abdominal imaging called an MRCP. We can also do an upper endoscopy, putting the camera down the throat to look at the stomach. From there, we can see the top of the pancreas or the head of the pancreas where some pancreatic cancer can develop. And finally, a last example on here is kidney cancer. If there's an increased chance for kidney cancer, we can do certain imaging techniques like an abdominal MRI. A lot of people have questions about insurance and family implications from genetic testing when they think about doing testing like this. And so to start off, the cost of genetic testing can be covered by insurance companies if you meet medical criteria, if it's deemed medically necessary by your insurance company. However, every plan, every deductible is a little bit different. So it's definitely important to know what yours is and check with your insurance companies on those. There's also a self-pay option now at some genetic testing companies that charge just a flat rate of $250 to do a panel test like we were talking about before to look at predispositions for cancer. So that can be an affordable way potentially to do that testing if insurance is not a factor. Next thing people sometimes ask about is discrimination. And there is a law called GINA, the Genetic Information Non-Discrimination Act, which was established in 2008, that says that health insurance companies cannot deny you coverage, cannot charge you higher rates if you do have a genetic predisposition. Same with employers. Employers can't hire or fire someone based on a genetic test result. Of course, this doesn't apply to everyone. There are loopholes to this, but that's the general idea of the law. What's not covered in this law is life insurance, long-term care insurance, and disability insurance. So those insurance companies can ask for someone's medical records. And if they see that you have a predisposition, sometimes they will deny life insurance or charge you higher rates for those insurances because of this hereditary predisposition. And that's something to be aware about before getting into genetic testing. Finally, what about my family? What does it mean for them? This is information that will impact your family members as well. So it's important to take them into consideration. And of course, it's every individual's choice whether they want to know this information or not. So we talked about all this great information about genetics, genetic counseling, and you're thinking, oh, it would be great if I could speak to a genetic counselor or someone who understands some of these genetic predispositions. And I have the information here right here for you. So if you go to findageneticcounselor.nsgc.org, there you can plug in your zip code, your city, find a genetic counselor or genetics professional near you to talk to about this information. We also have great resources here at UT Southwestern. So for our cancer genetics department, there's a phone number there. Option number 1 is our scheduling team. You don't need a referral from a doctor to schedule with us. You can just call and say, I have a family history of cancer, or I've had cancer and I'm wanting to do some genetic testing, or interested in talking to a genetic counselor about that option. We do in-person appointments in Dallas or Fort Worth, or we can also do video appointments via telehealth if someone is in Texas at the time of the appointment. We can also help in lots of different areas along the way with genetic testing. So in some cases, we can help in the pre-test scenario. Maybe somebody hasn't done genetic testing yet and wants to figure out if that's right for them and do a risk assessment. And then sometimes people have already done genetic testing and they have a genetic test result, but don't know what to do with that information. And we can help on that end as well, or all of it. And we actually have this wonderful new clinic called the Genetic Cancer Patient Clinic, or GCPC for short, as that's a mouthful. And this is a clinic for people who have a predisposition to cancer that is already known, but they want to make sure they're up to date on their care, and we can help coordinate their care all in one place and do that in an ongoing nature. So you're taken care of with your predisposition for cancer. And I won't go into this slide too much, but I just wanted to give a little intro to where Dr. Park is taking us. He's going to talk more about somatic genetic testing. So this is genetic testing of the cancer itself, which can be used to help inform cancer treatment. So I'll give it away to Dr. Park here to continue on.
You're on mute. There you go.
Yes. Thank you, Kelsey, and thank you to the organizers of the UT Southwestern Science Cafe. So pleased to be speaking with all of you tonight. I'm glad we have this opportunity to talk about something I'm very passionate about, which is using these genetic changes and this new type of genomic technology, looking at many genes, in order to inform the therapy of cancer. So here's just a vision, an overview of what we believe can be the merger of genomics into medicine. So we can envision a patient who has testing done, either of a tumor or their germline, or a representation of their tumor within their peripheral blood. And these are subjected to a technology. And this little cartoon picture here is actually the raw data that comes out of the instruments that allow us to test for so many genes. And this is a technology that has just emerged over the past decade. And by having information on so many genes in a single test, this gives the opportunity for physicians to now put together a comprehensive diagnosis that not only tells us what led to that tumor potentially, but then how can those changes be exploited to tailor very specific and effective therapeutics. So here's the first polling question, and this is the audience, and this will give us each a better understanding of who's attending today. So for those of you in the audience, do you or someone you know, have you had a cancer treatment decision based on genetics? Looks like we don't have any participants yet, but I'll just give it another moment.
There we go. And I don't know why they're all up at once, but you all go ahead and answer them all, and then we can be done with these. But we appreciate your input.
This is very interesting. I see the numbers come in. So most people have not themselves or someone they know have not received a cancer treatment decision based on genetics. It looks like it's the overwhelming group here. Now, just as an anecdote, I've run a genomics lab at the Children's Hospital where we've done cancer testing now for close to 8 years. And I can say within the last 2 years, I've started getting a lot more of those phone calls and calls from people I know in the neighborhood. So this seems to be something that is occurring more frequently. And certainly the data shows that we are testing tumors more frequently to understand how can we further address a diagnosis of cancer. So to put this in context though, right now, cancer diagnoses are still primarily done by the methods that's existed for hundreds of years, which is the microscope. And so I'm a pathologist, I still use my microscope, and that's still the mainstay. And it'll probably at least be that way for well into the next decade or two. However, what we started to see in the last 10 years is that more and more tumor types now require genetics in terms of making a definitive classification. It requires genetics in terms of really understanding what type of cancer a patient has and what that means for future risk of disease and what it means in terms of treatment. So this is rapidly changing and is certainly different than it was even 5 years ago. Treatment and management can now be based on a combination of microscopy, what I see under the microscope, as well as biomarkers. And that includes genetics as well as things like protein markers. A thing that we're not talking about today is cancer screening, and that is also an area that is undergoing change, and it seems to be a combination of microscopy, biomarkers, genetics, and that is certainly a field that is changing. Now, just to kind of summarize this in some ways, so if we think of the diagnosis of something like a lung mass, so a patient comes in with certain symptoms and they may undergo an imaging study which identifies a mass in the lung. So the traditional method of doing this and the mainstay is to get a tissue sample. In this case here, I've shown 2 examples of lung cancers. One is a squamous cell carcinoma on top, and below that is a neuroendocrine carcinoma. These are 2 types of lung cancers. But you see that on the far right here are very different treatment options depending on the histology or the microscopic appearance of that tumor. So microscopic subtyping is still very important. And you see that the menu of options for treatment, and some of these options are now combined together in modern practice, those rely on the histology and more so on the genetics. So here's polling question number 2. Currently, how many genes inform therapies? So I've written here, broadly speaking, is it 10,000 genes? Is it 1,000 genes? Is it 100 genes, or is it 10 genes? And this is a very interesting area also that is undergoing rapid change. So if we look at the polling numbers right here now, we see that most of you are choosing somewhere around 1,000 to 100 genes. So this is a very well-informed audience. I think it's very impressive. I guess it's self-selecting. For those of you that would seek out a weekday evening to spend with us. So if we look at this next slide here, I've tried to summarize, I update this slide every year. This is just a snapshot of genes, genomes, and disease. So we think about diseases. There are thousands and thousands of diseases, not just cancer, but all comers. And we know of about 7,000 diseases that have a known genetic change which leads to that disease. Now, how many genes are there? Well, there are several different ways of counting genes, and there's different types of genes, but a good number to use is about 18,000. So in that context, how many genes are known to cause disease? So not diseases caused by genetics, but how many genes, when they're affected or broken, I like that word that Kelsey used, cause disease. And that's about 4,700 genes. Now, the ones associated with cancer, there are about 1,000. But then if we think of the ones that will actually potentially be used to target therapy, it's much less. It's only about 200 genes. And that number is changing every year. It is actually a very dynamic number, but it's still a small number compared to the overall number of genes that are associated with cancer. Now, patients coming into the clinic that have cancer genomic tests, about 50% of them are thought to have a change which could be targeted with a therapy now or has a potential drug that's in development that may target their cancer. Now, along those lines, I'm going to go a little bit more into detail because this is something for those of you who have family members or yourself that is affected by cancer. You'll get back these reports and they can be very confusing because they're not, as of this current time, they're not really written for patients. And that's an area that's under change right now. But right now, they're not written targeting patients. They're trying to provide very concise information for the treating provider. And so here are 3 broad categories of DNA variants or DNA changes. Again, I like the word Kelsey used, how a gene can be broken. So one can be very simple. You could have a single letter of the DNA alphabet change, indicated here. If C is the normal, if it changes to a T, that can actually lead to a defect or can lead to a gene that's out of control. Another type of change can be an insertion or deletion of a string of letters of DNA. Here we see a patient sample with these 3 red dashes indicating that unlike the normal copy, the patient is missing 3 letters. And then finally, we have these global changes that can be quite large. And so not just impacting a single gene, but potentially impacting multiple genes, even thousands of genes. In this little picture here, this is actually an image of what's called fluorescent in situ hybridization, looking at chromosomes that have fused together. So we have a normal pink chromosome here in the bottom right, and a normal blue chromosome here in blue, light blue on the right. And then we see in the upper and middle, these little squiggly lines that are a combination of light blue and red. And that's when you have chromosomes that are abnormally fused together. And we have a variety of tests to look at these things. And these are all things that can be targeted by therapeutics. Here's a view that I look at. So if you want a snapshot into my daily routine, when we're getting back results of genomic tests, this is a screen. It's kind of like a map. And so you could see here in this map, it's for a gene called BRAF. And it tells me I'm on chromosome 7. And the big red area here, which doesn't show up in my daily view, but I'm just emphasizing to you here, is that it's showing you that there's a change in this patient's TG in this specific position. So this patient actually has what's called a deletion and insertion at that region. So that TG is now an AT, and that leads to a single position protein change. And this is something that leads to out of control signaling and can lead to cancer growth. So this is just a snapshot of what we look at. And at the very bottom here, you can see other pieces of information. The middle row here with the yellow letters, those are what we call population changes that don't necessarily impact or indicate disease. But then the very bottom here, all these plus signs and the pink and the red, those are actually known positions of where disease-causing changes may occur. Now, there is a system by which we are able to know about a common way of reporting these changes. I'm just showing this to you so that you understand that this is an area in development. The first system of trying to report things in a similar manner between different labs came out in 2017. And it's primarily tailored with the idea of, is this change in this patient's tumor, does it mean that there's a therapy that exists out there that is cleared and approved by the FDA? So that's what they consider the highest level of evidence. And then we go into this very large category that we run into every day in the lab, which is the patient has a variant, but is it linked to any therapeutics? Is there a clinical trial out there that indicates this change may be meaningful? So this is an area under development. We're just in the first 5 years into really creating a common language of reporting these changes. Now, there's a large menu of potential types of tests. There's not a single perfect test when we're looking at tumors. And the types of changes we look at are global changes. And for example, we could use a test called microarray. And here's a little picture of what that raw data looks like coming out of it. We can do targeted testing. And this is usually done in the context of where we're either confirming something or based on some other features that are going on clinically, we have a pretty high suspicion. And this is a very old technology that's been around for over 30 years. We also have something called fluorescent in situ hybridization, which I mentioned before. And then finally, the most powerful technology, which allows us to look at tens of thousands of genes in a single sample, is the so-called next generation sequencing, indicated by this picture here. Now, these tests, as an example, here is a study of 4,000 patients with lung cancer that I'm just using as an example. And they're using an FDA-approved test that looks at 395 genes. These are tested from existing tissue samples from a patient. And what I just point out here, and this is the uncertain part of this, there's a lot of promise here, but what you see in this figure here is that the dark blue line indicates the percent of cases that have a disease-causing change, and then the light blue indicates cases that have a change of unknown significance. You see for certain genes, like here at TP53, most of the cases have ones that are of known significance, but then we get to other changes, such as this in this gene, LRP1B, where most of the changes in most of the cases are of unknown significance. Finally, there are more and more therapies associated with genetics, and I just list, for example, here, specific gene changes that are linked with FDA-approved therapeutics. And the last two here are a very exciting emerging class of DNA testing linked to therapies. And these therapies are the so-called immune checkpoint inhibitors or immunotherapy, which, unlike looking at the specific changes in DNA, you're using changes in DNA to activate, we use a drug that activates the patient's immune system. Now, the final part of this, that I'd like to tell you this because this is an area that's changing quite fast, is that traditionally, the only way to get at genomics is to directly get access to tissue. And that would be either through a biopsy. So in the case of a lung cancer, you could do a transbronchial biopsy, or perhaps a surgeon would go in and do a minimally invasive wedge resection to get a piece of that tissue. What's emerged over the last 20 years is a new technology called peripheral blood testing of tissue. So you're using the peripheral blood to get sampling of tissue. It's also known as a liquid biopsy. The other terms you'll hear are cell-free DNA or circulating tumor cells. Now, this has, again, been around for about 20 years. About 20 years ago, someone made the realization that in pregnancy, a mother, you could test her peripheral blood and have insight into the genetics of her fetus. And this is so-called NIPT, or non-invasive prenatal testing. The exact same technology is used to sample the cancer tissue in the patient's blood. And there are a number of other uses of this type of technology that are emerging. Now, why would you use one or the other? Well, there are some very good reasons to use cell-free DNA or a liquid biopsy. First is that the risk of the procedure is very low. It's only a blood draw, it's standard phlebotomy. Versus a tissue biopsies can have risks depending on the location, especially if you think of the lung or the brain. Second is, if you're looking for cell-free DNA to do serial measurements, before and after a therapeutic treatment, it's much easier, again, to access blood rather than tissue. Now, cell-free DNA or liquid biopsies, it's not cheap. It can be several thousands of dollars per test, but that's cheaper than tissue when you consider all the expenses that go into getting access to tissue. Everything from going to a surgical center, getting imaging, anesthesia, pathology, radiology. So it is cheaper when you think of the whole process that's going on. Finally, and the most important thing to remember is that the diagnostic value of cell-free DNA is still emerging. It's very powerful, but there are a lot of caveats to it, and tissue is still the gold standard. Now, this is the final evidence piece that I'll give to you here, is that don't be taken aback if you ever have both of these tests done and the results are different. That is something known to frequently happen, and there are some very simple reasons, such as the fact that most tissue-based tests will look at a greater number of genes, for instance, commonly hundreds of genes, where most liquid biopsy tests or cell-free DNA tests will look at less than 100 genes. So first off, there's a major difference. The second is a difference of sampling. When you're doing a tissue biopsy, you're going to a very small region of the tumor. Whereas in theory, the liquid biopsy is taking, a sampling, all the blood washing over the entire tumor. Now, the final thing is that tumors change over time. They're dynamic. And so if there is a period of time between the two tests and you had both, that match rate goes down rapidly. It's about a 75% at best match at 1 week, down to less than 50% match at 1 month. So these are tests that are both trying to sample and give us information of the genomics of the tumor, but they're not always concordant. They don't always match. So I'm just going to close the end of my talk here, and then we'll go into the Q&A session. But just really concluding that cancer genomics has become a standard of care over the past decade. Many patients are being tested, having their tumors tested, especially in cases of advanced cancer. Tumors are routinely tested, not only to aid in diagnosis and classification, but again, for treatment and management. And finally, we have this new type of technology that allows us to evaluate the tumor genetics through peripheral blood, rather than directly accessing the tissue through biopsy or surgery. Thank you again for joining us tonight, and we look forward to your questions.
Thank you, Dr. Park and Kelsey, for your presentation this evening. And we'll now move into the Q&A portion of this program, starting with questions submitted in advance by registrants before going to any questions that we may receive in the chat. So the first question is the current BRCA genetic testing as accurate for African-American women and other demographics? And if not, what genetic testing is most accurate, predicted for generic testing?
I can take a stab at this one. I will say, first off, there's been a great injustice done in genetic testing and genetic research overall, in the fact that most of the research has been done on white individuals over time. And this is something that definitely needs to change so we can have data that represents the population as a whole. And that's very important for us going forward. However, a BRCA testing for an African-American woman can still be accurate, where sometimes we can reflect a little bit of confusion and is in that classification when we talked about positive versus negative versus uncertain. Maybe since we don't have as much research to back it up for this population, we may see more uncertain results in different populations. And so that's something to keep in mind. Also, something to keep in mind with BRCA testing is often there are other genes associated with hereditary breast cancer, and we want to make sure we're doing comprehensive testing of those BRCA genes, but also of other genes as well, if that's indicated for you. And so that's definitely something to talk about with your providers or with genetics professionals.
Thank you, Kelsey. And so the next question is also about BRCA. And the question is, if a man has a mom who has a BRCA2 carrier, BRCA2 carrier, and had breast cancer and ovarian cancer, and he himself has tested and confirmed to be a BRCA2 carrier, what suggestions do you have to prepare him for the future?
That's an excellent question. And I would definitely say that that person could maybe get some value from genetic counseling or speaking with a genetics professional personally about their specific situation. But in general, for men who have a BRCA2 mutation or a carrier of a BRCA2 mutation, they do have an increased risk for male breast cancer. And we do want to recommend that they start self-breast exams and learn about those around age 35. And then we also want to make sure they're getting clinical breast exams every year at that time. And then they can also consider doing mammograms themselves starting at age 50 is what the National Comprehensive Cancer Network recommends at this time. And I will say definitely refer back to those NCCN guidelines as they do change and update over time. That's currently for male breast cancer. With BRCA2, there is also an increased risk for individuals to have pancreatic cancer. Potentially, and for if there's pancreatic cancer in the family that has the BRCA2 mutation, then it can be recommended to do some pancreatic cancer screening like the MRCP that we talked about previously before. There can also be an increased chance for prostate cancer for men. And so starting PSAs and digital rectal exams around age 40 is the NCCN guidelines there. And then finally for melanoma, a risk for skin cancer, getting full body skin exams every year is important too. And I threw out some ages in this, and that is just based on the general recommendations. If there is a young cancer in the family, then that age may change depending on the family. So very important to talk to doctors about your specific situation.
Thank you. I'm going to give you one more question that was pre-submitted, and then we'll go to the chat. The next question is, how does the issue of pre-existing conditions intersect with genetic testing?
I touched on this slightly in the presentation when it comes to the Genetics Information Non-Discrimination Act, and that it does not apply to life insurance, long-term care insurance, and disability insurance. So sometimes we can kind of think about it as those companies are looking at this as a pre-existing condition and using it to, charge you higher rates or deny you those coverages because there's no protection in place for them, except for in Florida. So maybe more states will come soon, but that is something to consider for sure.
Thank you. So now I'm going to go to the chat, and we have a chat from Sarah, and her question is, when you identify genetic risk for cancer for an individual, what do you discuss in terms of testing for their children and relatives?
That's a great question. We definitely want to recommend testing for the family member at an age appropriate time. So certain adult onset conditions, we want to make sure the person is 18 or older where they can make their own decisions about their healthcare. However, if we're concerned about a childhood predisposition to cancer, then that may look a little bit different. But it's something that we usually in our program, we send out family letters, which is a short, sweet version of what's going on for the person in the family that has a predisposition that they can take to their doctors, or they can take to genetics professionals to say, hey, here's what's in my family. Here's what I need testing for. Can you help me walk through this process?
Thank you. Can you touch a little bit on privacy issues with the results of genetic testing?
Sure. So of course, when you do genetic testing in a clinical laboratory setting, a lot of them do follow HIPAA privacy policies, which means they are not allowed to share this information willy-nilly with just anyone, and they have to have your consent to share this information. And as a medical institution, if you're getting your genetic testing done at a healthcare facility, it's also protected under HIPAA privacy policies. And so therefore, it's just shared with individuals you want us to share with, such as your other healthcare providers or doctor that's going to take care of you moving forward with this predisposition. So the information is kept as private as possible, but we do know leaks happen, data breaches happen in different circumstances, and so we must be aware, but everything is being done to keep your information as private as possible when done in a healthcare setting.
Thank you. My next question is for Dr. Park. If a child has cancer, what kind of standard or extra screening should they do as adults?
I'm actually going to refer that to Kelsey.
Okay.
Sorry, could I get that question one more time?
Yes. If a child has cancer, what kind of standard or extra screening, maybe this should be if a child had cancer, what kind of standard or extra screening should they do as an adult?
So that's going to probably depend on the type of cancer and the type of treatment that they've received over time. So again, best to talk to their oncologist or their medical providers that have taken care of them for that cancer, determine what cancer screening should be done following that cancer diagnosis and what their risks are for cancers in the future. If they also happen to have a predisposition that goes along with it, then maybe there's a couple of factors that we have to consider, not only the risk from their previous cancer and previous treatment increasing the risk for cancers in the future, but also a predisposition. So it can be a lot of different factors playing a role there in determining that screening.
Okay, thank you. Okay, the next question is, when a female is diagnosed with breast cancer at 28 years old, is it necessary for her brother to be genetically tested?
In this case, the best person to test in the family is going to be the sister who had breast cancer herself at 28 years old. When we test someone who's had that cancer that we think may be hereditary and we find a genetic predisposition, it's a lot easier to test the other family members for it. However, the brother does meet criteria for genetic testing if the sister has not had genetic testing and he is wanting to know for himself, but maybe his sister with breast cancer decided not to get that genetic testing done. He would still be able to do that because we know it could still be information that affects him going forward.
Thank you. So the next question, this has been addressed in the presentation, but it's still a good question to recap your remarks. Can we predict or simply be aware of potential future cancer based on studying one's genes?
Absolutely. We can know that information in a few different ways. So when we think about genes that we're born with, that can definitely help tell us, is there a broken gene that predisposes us to cancer where we need to watch more closely for certain types of cancers? And then, of course, on the side Dr. Park talked about, if there is a treatment based on those broken genes and the cancer itself that could help for them too.
Dr. Park, is there any other information that you would like to share with our audience this evening?
No, I think it's something to consider. If you yourself or you have a family member who is diagnosed with cancer, and especially in the scenario, if they are not responding to initial first-line therapy, it is something to bring up with your healthcare provider to ask whether it would be helpful to test your tumor to see whether or not there is a standard therapy or whether it would allow enrollment or eligibility in a clinical trial.
Thank you. How do you suggest that one would open a conversation about genetic testing with their doctor?
I'll start this, but I think Kelsey will have a better answer because she deals with this all the time. I think surprisingly, a lot of folks, depending on what your doctor's experience with, they may not know where to send you or refer you to. So that's why I think it was really helpful that Kelsey put that link about where to find your local genetic counselor or local genetic practitioners. I even have physician friends that say, oh, I have a patient, I think they have a genetic syndrome, but I don't know where to send them. And I would say, is there a genetic counselor in your community group? And they'll say, oh, yes. Then that's the answer. But even among healthcare professionals, this is something that is rapidly growing. But people of my generation, which is, who went to school 20 years ago, they may not really be attuned that in knowing that genetic counselors and medical geneticists are there and are more than happy to help guide patients through this process.
Kelsey, do you have anything that you would like to add?
No, Dr. Park said that in a beautiful way. I would just add that we all know that sometimes you have to be an advocate for yourself in healthcare situations. And so just saying, hey, is there genetic testing that's appropriate for my cancer or based on my family history of cancer that's happening, and asking that to your doctor could maybe prompt them to think about, oh, yes, actually, let's refer you over to genetic counseling. And it may not have been a piece that they put together themselves because they're focused on lots of other ways they take care of you. And so sometimes just that little prompt of saying, hey, what about genetics can be enough to help place that referral or to answer that question for you.
Thank you. Our next question comes from Rick, and he asks, has there been any advances made in identifying genetic markers for, genetic markers for pancreatic cancer?
Again, I'll start on this, and I'm sure Kelsey will correct me if I say something wrong. But this is an area that has rapidly progressed over the last 40 years, where we know there's a lot of hereditary diseases that predispose individuals to pancreatic cancer. Things that would cause a long-term inflammation of the pancreas, for example. And then we also know that pancreatic cancers are part of other syndromes. Kelsey had mentioned BRCA2 is one of them. And beyond that, there are also in families that pancreatic cancer runs within the family, there are better and better models for screening and earlier detection.
Thank you. Our next question comes from Joya Lane, and Joya asked Dr. Park, what are some exciting recent discoveries that you and your team have found in your genomic medicine research?
Oh, that's a great question. It's not just about cancer that genomic medicine is changing things, but it's also across many diseases. An area that clinical group that I've been really involved with is pediatric epilepsy. And I think that that's really changed over the last 10 years, where we know that a lot of patients with, non-responsive epilepsies to standard drugs, you can actually find different ways of managing those epilepsies based on the genetics. So that's been a really exciting area. But I think overall, when I started in this field about 12 years ago, the number of diseases where genetics was common was actually genetic testing was quite common, was pretty low. But with the advances in technology and advances in research, we certainly see that there are many opportunities. And we're just still at the beginning, I would say, of how we can use genetics to tailor and predict risk, and then also to treat disease.
Thank you. We'll take a couple more questions. The next question comes from Deborah. And Deborah would like to know, do you think someone can be too old for genetic testing?
So if you're wanting to know that information, either for you or for your family, I say never too late. We would always want to talk to you about those risks and what that can mean for you or what that can mean for the family. Sometimes when someone is an older individual, maybe they don't feel like they'd use that information so much for themselves, but they really want to do it for their family because maybe they're the best person to have that genetic testing in the family. So always something to consider, and it never hurts to mention or ask to see if it's still appropriate for you.
Thank you. Our next question comes from Maria, and she would like to know, when managing active malignancy, are there current guidelines in place to help oncologists determine the frequency of genetic retesting, given the likelihood of accumulation of new mutations over time?
That is a wonderful question. So I'll start by saying that there are very good guidelines for when to do initial genetic testing and when that genetic testing of tumors specifically can be helpful for therapy. But I'm actually not certain, and maybe Kelsey could help me with this, but I'm not sure if there are NCCN guidelines for different tumors that actually talk about when a patient should have their tumor retested. It's very well understood now that tumors will change over time, but I personally I'm not familiar. I know of a handful of cases personally where the patient had their tumor tested multiple times over the course of disease. That's outside of a research context. In the research context, these retests happen frequently. Kelsey, do you have any other thoughts on that?
I don't. I feel the same way you do. Most oncologists are going to be the people who are most aware about those types of guidelines specifically. But since this is such a new area of study, there's often not guidelines when we are at the forefront of new information and the new technology to be used. So there are some studies out there and some research studies going on to determine what is the most appropriate timeline. And so you'll see that information start to come out here soon. Definitely something to check NCCN guidelines for it, and your oncologist would typically be the one to do that.
Thank you. One last question, and this question comes from Javelin. Dr. Park, how often is cfDNA used for testing?
In the context of cancer, the use of liquid biopsies, it really depends on the tumor type and the center that is using or treating the patient. So it's quite different. And I would also say that my colleagues in Europe, they use this quite a bit more than we do, and they've had many more years of experience. They've been using liquid biopsies as standard of care for almost 10 years, where I haven't really seen it become widespread in the US until about the last 5 years. So I think, this whole area, and I think Kelsey's kind of touched on it, it's changing quite rapidly. And so it's exciting, but then as professionals, it's also disconcerting that we know that, a lot of what we're saying now is good for the moment. And I think we tell this to our patients all the time that, a really important aspect of genetic testing is once you get that result back, if your disease changes or, if you want more information, it's important to get in touch again with the genetics clinic and see if things have changed, even with this diagnosis you might have had in the past.
Thank you so much for Kelsey and Dr. Park for your presentations on cancer genetics and for this insightful Q&A session. I've really enjoyed it. It was some incredible information and a lot to think about. To our guests, many thanks for joining us tonight for Science Cafe and engaging with us with your questions. Thank you also to Charlie and Jovelyn and our colleagues, Leslie Pomeroy, Sarah Prezade Miller, Renee Barber, Rick Press, Amy Israel, and more that I can't think of, Sierra and India, for helping put together tonight's program, for sharing it out on social. We are finalizing our program details for April, and we'll be back next month with another episode of Science Cafe. So be looking for emails in the coming week. And for now, we wish you all good health and wellness and a good night, and we are adjourned. Thank you.